Hello, this is Dr. Hiroshi Mitsumoto from Columbia University Medical Center in New York. Welcome to this infographic-based education activity on ALS.
The following podcast is part of a certified educational activity titled Assessing the Role of Recent Therapeutic Breakthroughs in the Treatment of Amyotrophic Lateral Sclerosis. Access the entire activity and complete the post-test at www.peerview.com/TMS. Downloadable infographics and additional resources are also available.
What is ALS? So this is a progressive neurodegenerative and neuromuscular disease. The new patient, usually 5,000 patients in the United States. We have probably 20,000 plus patient prevalent. And about 5 to 10% of cases are familial. Patient average life expectancy is 2 to 5 years, yet a good proportion of patients, close to 50%, lives beyond 5 years, and 10% live beyond 10 years and more. So, clinical symptoms and the presentation of ALS. The patient develops upper motor neuron, lower motor neuron symptoms. Upper motor neuron predominantly is characterized by some awkwardness, slowness, and difficulty using legs smoothly. For example, a patient who has upper motor neuron sign in the legs feels like legs cannot be bent, almost like a piece of wood type of walking. And then lower motor neurons characterized by fasciculations and muscle cramps, which is very common in the patient. Yet those also occur in healthy people. Therefore, you cannot make a diagnosis based on those fasciculation and cramps. Nevertheless, if patient says no cramps or fasciculation, you wonder if you are dealing with motor neuron disease. So lower motor neuron disease characteristically develop weakness and muscle atrophy. Approximately 2/3 of the patients develop limb weakness, and a good proportion, more than 40%, arm onset, and 1/3 of patients develop leg onset, and approximately 1/4, 25 to 30%, develop bulbar symptom. That means speech problem and the swallowing problem, and so forth. In upper extremities, most common symptoms are skilled arm and hand functions. For example, writing, use of fine motor skills involved. Also, it is important to say ALS always begins in focal region and then gradually, regionally spread to other part of muscles in one extremity or both extremities, often the same side, and then develop to the other side. So we have to identify both upper motor neuron and lower motor neuron signs, at least one region of body, and then we have to identify disease progression. Sometimes disease progresses very slowly and atypically, and therefore not easy to make diagnosis. On average, it takes about 12 to 14 months to make diagnosis. Also, you have to make sure the disease is progressive. That information you can get from the patient. You have to make sure proper question. The weakness is progressive. Also, more problem or symptoms added from original signs or symptoms. Well, the problem is sometimes those uncertain diagnoses lead to inappropriate surgery or therapies, particularly carpal tunnel release or cervical or lumbar laminectomies. Very important point is if you're not sure, you have to get second opinion always to get a diagnostic opinion from ALS expert. When you suspect a patient may have ALS, you have to proceed laboratory studies. That means blood studies, various studies we can talk about shortly, and also EMG. Make sure you get the brain, if necessary, cervical, lumbar MRI. If you cannot get MRI because of some pacemakers and so forth, you should get the CT scan at least. And when you have a patient notice some atypical features, such as the disease too fast or too slow or too young, or some atypical features, some sensory symptoms or other unusual features, usually you get spinal tap, CSF examination, but we use CSF examination less and less. ALS differential diagnosis. So certainly we are talking about motor neuron disease, but could be some other motor neuron disease. This could be paraneoplastic and other cause. So make sure we are dealing with idiopathic or unknown cause of motor neuron disease. But motor neuron disease can be motor nerve disease. That means motor neuropathy. Sometimes cell body disease and nerve disease are very difficult to differentiate because after all, they're the same cell. But you have to do EMG. Make sure this is not the multifocal motor neuropathy with the conduction block. EMG studies is becoming very important. Sometimes we get anti-GM1 and other studies, but exceedingly rare to have anti-GM1 antibody becoming positive. So how about neuromuscular junctional disease? Yes, myasthenia gravis and myasthenic syndrome. You can get blood studies, particularly bulbar symptoms, sometimes mistaken with myasthenia gravis. So you have to get the proper blood test and also very good EMG studies. How about the structural CNS spinal lesions? Of course, we have to get MRI and make sure we are not dealing with unusual disease in the brain or spinal cord, which is most important. How about the myopathies? Sometimes inclusion body myositis mimic motor neuron disease, particularly lower motor neuron type. So you have to get, again, very good EMG and also CK, but those are sometimes mistaken. Endocrine disorders such as diabetes and parathyroid, thyroid disease, electrolyte abnormalities, those can be mistaken as motor neuron disease. So those are differentiated by proper use of a diagnostic test. The Escorial and Early-House ALS diagnostic criteria. You have to identify upper motor neuron signs, and also you have to identify lower motor neuron signs. Those are in 4 body regions: cranial nerve regions, cervical regions, thoracic regions, and lumbosacral regions. Of course, right and left, except for cranial nerves. And lower motor neuron signs by clinical examination or EMG, and disease is progressive. You rule out structural disease, sensory involvement, other unusual disease can be diagnosed by EMG. Those must be excluded. That's the basis of Escorial and Early-House ALS diagnostic criteria. So I would say ALS-FRS-R revised scale is one of the most important or the most important scale for ALS. We can use at the clinic. We can use clinical trials, clinical research, and patient care, in fact, and the most widely used and most widely validated and very reliable scale. AAN ALS Care Practice Guidelines, which is so important, and everyone, including any neurologist, should know about clinical practice guidelines for ALS. And that was 2009, old, but still very valid. The patient should be followed at multidisciplinary ALS clinic, which they recommend, and very important. No. ALS symptom management. Weight management is so important. Actually, I tell the patient weight management is the most important thing they can do. So spasticity is very difficult to treat, and you can use muscle relaxants such as baclofen, tizanidine, but more importantly, spasticity in the legs can cause falling. Therefore, assistive device such as cane or walker to prevent the falling, and also frequent small exercise, stretch exercise is very important. ALS can be quite painful because of spasticity, muscle cramps. Patients sit in the same place or wheelchair for hours, which cause tremendous pain. Yet, those pains should not be treated with opioids. You can use, if you have used medications, ibuprofen or naproxen, and sometimes gabapentin type of medication. And sometimes, of course, you can use tricyclic antidepressant. You should use physical treatment I mean range of motion exercise, massage, heat, and TENS unit. Also, you can alternate ibuprofen, naproxen, aspirin rather than continue to take those medications. However, opioid can be used for the palliative and terminal care. It is very important to know that. How about the sialorrhea or drooling? Yes, you can use anticholinergics. Glycopyrrolate is probably first line of treatment. You can use atropine, particularly atropine eye drops into the mouth, and tricyclic you use, but difficult case, sometimes Botox injection can be done into salivary glands, and sometimes also radiation therapy for salivary glands can be considered. How about the muscle cramps? You should use baclofen and mexilatin and other medications. But again, cramps can be very, very difficult. Dysphagia, yes. So obviously, it is important to change food form, easily palatable food, smooth textures, so make them easy to swallow. Use of thicket to make thin liquid a little bit thicker, to take fluid and so forth, and follow weight and any weight loss with the maximum trials. This is the time to think enteral feeding, such as the PEG. We rarely use parenteral feeding though. So dysarthria is very difficult problem. So it is necessary to start early interventions such as augmentative assistive device, writing board, introduce those alternative communication is very important. The final stage is someone who cannot talk and tracheostomized and so forth. Brain-computer interface is available, but still a development stage, I must say. DVT is not rare as we think. Hydration, positional change, passive exercise, compression boots are very important. So prevention is the key. And respiratory insufficiency at the ALS multidisciplinary clinic will check pulmonary function. Anyone if we see below 50%, we start using NIV, non-invasive ventilators such as BiPAP. I believe non-invasive ventilator is probably the best assistive device we developed in the past 15 or 20 years to ALS field. So this is a very important assistive device. Again, you need to think some other cough assist at the same time, and also nebulizer to moist airway. That's very important. And the pseudobulbar affect, which is a fairly common problem, forced laughing or crying easily, uncontrolled, abrupt. And now we have a very good medication, dextromethorphan, quinidine. Depressive symptoms, not necessarily depressions, are frequent, but depression itself is relatively rare. About 10% of early stage patient and 10% of late stage patient develops depression based on diagnostic criteria. But again, we can use some antidepressant counseling, and very important to let them learn how to manage this difficult process of dealing with this difficult disease. Cognitive impairment is very common. Severe cognitive impairment occurs 5 to 10%, but if you do sophisticated neuropsychological testing, up to 50% of patients have some kind of a frontotemporal cognitive impairment. So it's very important to be aware, because those who have frontotemporal cognitive impairment is non-compliant, difficult to follow medical recommendation. So a patient caregiver should know, and we should know who has frontotemporal cognitive impairment. So ALS is clearly fatal neurodegenerative disease of human motor system. Yes, it is. But very important to emphasize the positive aspect. If you find anything a positive aspect in patient, emphasize rather than negative aspect. It is true this is difficult disease without any doubt. And also, there is no definitive diagnostic test. In fact, we cannot order some tests to make a diagnosis unless clearly familial disease. So we have to make diagnosis based on clinical findings, upper motor neuron, lower motor neuron, disease progressions, and exclude all other possibilities. That's the diagnosis. And then, very important to know that symptomatic management remains to be cornerstone of treatment for a patient with ALS without any doubt. You have to do as much as you can. Treat all symptoms, not just all we mentioned, but also constipation, insomnia, and many other symptoms can occur. So as a physician, we have to do as much as we can. The Riluzole for the treatment of ALS. So we have been using Riluzole past 23 years, and until last year, Riluzole was the only medication. Riluzole, the true mechanism is not known, said to be anti-glutamate or anti-excitotoxic medications. The medication slow down disease. Actually, this is the only medications, and I tell the patient if they don't have any side effect, might as well they should take. Not randomized control studies, but retrospective studies, observational studies showed patients who take Riluzole lives up to 20 months or so compared to those who did not. So I think we should continue use of Riluzole. How Riluzole are approved? There are 2 studies done, and last study showed Riluzole are better in terms of bulbar onset and better in limb onset and some muscle strength. But overall, survival was a primary endpoint, and the survival showed a few months of survival benefit with these medications. So that's the reason people think this is modest. But again, only medication available until last summer of 2017. So there are some problems. For example, very common to note fatigue or asthenia, gastrointestinal side effect. I told the patient, particularly nausea or abdominal pain or diarrhea or unusual constipation, stop the medication because if they continue medication, it gets worse. And also, as recommended, I advise to get blood tests, routine blood tests such as metabolic panels and CBC every 3 months by the primary physicians. Make sure if something transaminase is abnormal and so forth. But tell the patient is exceedingly rare. So next medication is the darabond, which was approved in Japan 2016 and came to United States, and FDA approved this medication without any additional studies in the United States. This is said to be free radical scavenger antioxidant. So darabond first study was done. And as you can see, there are inclusion criteria and 12 weeks observations, and then randomized and 24 weeks. And the study was in fact negative. But they analyzed data, and this is a post hoc analysis. And the post hoc analysis surprisingly showed that if patient has a certain, such as FVC is more than 80%, or 2 points in all items in ALSFRS-R showed some statistical significance. Then if you add more to definite and probable, and within 2 years of symptom onset, more clearly difference between treated and untreated. That was very encouraging. Good things this study group immediately followed this post hoc analysis, and they studied next one. And the end result came very different, and p-value of 0.0013 and significant difference. Based on this result, Japanese regulatory agency approved darabond for the treatment of ALS, and the result came to FDA, and without repeating any studies, they approved. Adverse effect profile is not different between darabond and placebo. So this was very encouraging, and good things we have 2 medications now for the treatment of ALS. But again, those are very important because we have more control. Patients have control to use 2 medications combined, or most importantly, if patient cannot take Riluzole, they can take darabond. So we have a better control. And certainly we hope we will have a better medication, number of clinical trials going and early stage. And one study is masitinib, which done in Spain, only one center showed benefit. It is very important bring the patient at the best conditions, so if any new medication comes, you can expect a better result. Also, if patient conditions well maintained, a darabond and Riluzole benefit can be maximized. So as I said, Riluzole and darabond the main treatment, and we hope other medications coming. We need to follow clinical practice guidelines for the treatment of ALS. That means patients should be followed by an ALS multidisciplinary clinic.
This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/TMS. This activity is supported by a scientific educational grant from Mitsubishi Tanabe Pharma America Incorporated.